Hello and welcome. Thank you for joining us today. Today we are having a question and answer session with Associate Professor Salmaan Qureshi, and we welcome all of you. My name is Sabine. I work with the education team at the Macular Disease Foundation. I'm also an optometrist in practice, and I will be facilitating the webinar today. So firstly, there's a little bit of housekeeping that I'd like to go through. You will notice that all the microphones and your cameras are switched off, and we do that because we have a lot of people on the webinar and the platform works better when we do that. If you are having trouble hearing us or if the screen is frozen, then please try refreshing your screen. And if that doesn't work, then I suggest you call our 1-800 number, 1-800-111-709, and someone there will be able to help you. Now, if we can't hear you and we can't see you, how are you able to interact with us today? And you can do that by entering a question into the question box. So here I have taken a screenshot of that panel to the right of your screen. And at the top here where the arrow is, you can see there's a speech bubble with a question mark in it. If you have a question that arises during the webinar, please click on the little speech bubble, go down to the little white box at the bottom, type in your question, and then press send. Just so you know, those questions go directly to the organisers. So there is no such thing as a silly question. You can ask any question, but we do ask that you keep the questions in a general nature. If it's something very specific to your own care, that is something that we will not be able to answer today. As we move down that panel, you can also see that little red glowing light. That just shows that the webinar is in progress. Below that, you can see the 4 little arrows which are diverging. That just is where you click if you would like the screen to become larger. And then at the very bottom, you can see the exit. Don't click this now. We want you to stay with us to the end of the webinar. If you click that now, you will exit the webinar. So today's format is a little bit different to our usual webinars. We are doing a question and answer format, and you'll remember when you registered, you had an opportunity to ask your questions. We will be going through those questions, and then at the end, if there's any additional time, we will also attempt to answer as many of the questions that might arise during the webinar also. I would like to now introduce Associate Professor Salmaan Qureshi. Dr. Qureshi is a specialist ophthalmologist who focuses on the retina. He is a Principal Associate at Eye Surgery Associates, which is an ophthalmology group in Victoria. He is also Associate Professor of Ophthalmology at CIRA, the Centre for Eye Research Australia, which is affiliated for the University of Melbourne. And he is also a consultant ophthalmologist in the Medical Retina Clinic at the Royal Victorian Eye and Ear Hospital. I'd like to welcome Dr. Qureshi.
Yeah, good morning, Sabine. Thank you for having me, and good morning, everyone. I'm not familiar with this webinar, but let's see how it goes. I'm looking forward to answering lots of questions.
Fantastic. Well, let's get started. We'll get straight into it, Dr. Qureshi. The first question is, can I postpone my eye injections until after the COVID-19 restrictions are lifted?
So that's an excellent question, and it's very topical, and it's obviously come out, it's a very frequent question over the last few weeks. And because this is being recorded, I thought it's important to say that we're in Australia and it's May the 6th. And it appears that we've entered the phase of this pandemic where we have to learn to live in a new reality with the COVID virus circulating, at least to some extent, in the community. Now, a month ago, when we were experiencing 100 cases a day in Victoria and New South Wales and other places, then the answer may have been to delay. And we were delaying patients as much as possible, except if they had an immediate sight-threatening condition that could not wait. But thankfully, that episode has passed, and our community transmission is very low across Australia. And I think all chief health officers are of the same advice that it's not appropriate to delay medical care. And you should continue your medical care. If you need to see a doctor, you should see a doctor. If you're having an eye injection that is a sight-saving injection, that shouldn't really wait in these circumstances. So what was true in early March is no longer the case, thankfully, and I think it is appropriate to continue your care. And when you go and see your ophthalmologist, you'll see that things have changed in several ways. So, for example, you can see that I'm dressed in a scrubs for work. That's what most of my colleagues are doing. We change our scrubs every single day. I change my scrubs in the garage before I come into the house. When you go into the practice, you'll see that the doors are open, that there will be plenty of hand sanitizer, that there will be social distancing, that there will be a limited number of people in the waiting room. We're asking patients to wait in their cars as long as possible until the exact time of their appointment. There'll be fewer. We're encouraging people to bring fewer people with them so that there is no crowding. The instruments and surfaces and doors, etc., are being constantly cleaned. So the risk is being minimised as much as possible.
Mm-hmm. I have another question that's related to that very question also, Dr. Qureshi. This person writes, my mother is in residential aged care. They are currently on a lockdown. Am I still able to take her for her appointment to have her injections?
So that's a very good question. It's also very topical. There has been a divergence of opinion between elements of the assisted living community organisations and the government in this. The chief medical officers all over Australia have been of the view that restrictions should not mean complete isolation, and healthcare is important. Now, if you are attending, for example, a routine appointment that can be delayed, then you should try and delay it if it's possible. But eye injections generally cannot be delayed, and they are sight-saving, sight-preserving. So I think you should attend. There will have to be some negotiation with your nursing home or assisted living facility. Some people in some facilities, they say a 2-week post-visit quarantine, which I think is a little bit extreme, but I still think it's very important to attend your appointment if you're having a sight-saving therapy, which anti-VEGF injections into the eye are. And the chief medical officers nationally and in each state are of exactly the same view.
Mm-hmm. So moving on to some more generalised questions. These are, of course, the questions that were submitted during the registration process. Both parents had macular degeneration. So what are my chances? Note, I have never smoked. And then there's an additional one which I grouped with it because they're quite similar. My father has been diagnosed with wet AMD in one eye. What's the chance for me to have AMD when I am over 50, and how do I prevent it?
Both very important questions. Unfortunately, there is limited evidence that we have a preventative strategy for macular degeneration, and that's diet, exercise, etc., and vitamin supplementation. So the evidence base for preventative strategies are limited. However, there are several things that you can do. The first is to have your eyes checked, to be checked by your optometrist, and they'll be able to tell whether you have asymptomatic signs of macular degeneration. What that means is even though you don't have any symptoms, you may have changes that are suggestive that you're vulnerable to AMD. Now, macular degeneration is widespread the genes for macular degeneration, are widespread in the community. And that is because macular degeneration happens not only after you have children, but after generally you have grandchildren. And so the gene is widespread over many generations. And so even if your parents did not have macular degeneration, there is still a risk that you may have it yourself. So at age 50, I would recommend that everyone have a comprehensive ophthalmic examination with their optometrist, who can then screen them for a variety of conditions, macular degeneration, glaucoma, etc., and take it from there. And then you should have a relationship with your optometrist. Generally, it's good to have a relationship with the same optometrist, to have your eyes periodically checked. When you're having glasses, to have a check of the back of the eye for all of those things. Now, beyond that, I would say generally people should stay healthy, maintain good health, exercise, physical fitness, etc. Because one of the most difficult things is to give up treatment in a patient with macular degeneration because they're not well enough to come in. And so if you keep yourself active physically and in good shape, then it's likely that should you develop macular degeneration, you'll be able to persist with your treatment far longer than if your health is not good. Finally, the point about diet, multivitamins, etc. Multivitamins are useful in a small number of patients with moderate or advanced disease. Unfortunately, there is no evidence that they work as a preventative strategy, and that has been disappointing. But I would strongly recommend that you have a diet rich in green leafy vegetables, coloured fruits and vegetables which contain phytochemicals that are protective of the macula, and have a diet that is good for the rest of your body. So that means not a lot of refined carbohydrate, added sugars, low saturated fats. All of the things that are good for the other cells in your bodies and the organ systems are good for your retina and your macula.
Mm-hmm. And of course, don't smoke.
Yes, yes, of course, goes without saying.
That's the big one. The Foundation does a lot of work around the diet and lifestyle changes, and of course, helping people to quit smoking is a large part of that as well. What about in terms of the family history, Dr. Qureshi? If your father has been diagnosed, or if both parents are diagnosed, does the risk change much between one parent having AMD and both your parents having AMD?
So the answer is it depends on what genes they have and the combination and the mutations in those genes. But generally, the higher the family risk, the higher your individual risk. And it also depends on how aggressive your parents' condition is. If they have very aggressive disease that came on at a young age, relatively young age, then you're more vulnerable than you would otherwise be. But what happens in one generation is not always true for the next generation. And remember that over time, our treatments are going to get better, our diagnosis is going to become better, we're going to treat disease earlier, and our results are getting better as well. So what happens with your parents is not necessarily what will happen to you.
Mm-hmm. Great. So we're going to move on to treatment. So what is the latest treatment for wet AMD, and how does it work? And how does it compare to Lucentis, which of course is one of the anti-VEGF injections, in case someone doesn't know?
So before I answer that question, I should point out that I don't have any industry relationships. I don't consult for a pharmaceutical company. I don't have shares or stocks in a pharmaceutical company. I don't speak or receive any remuneration from any pharmaceutical companies, device manufacturers, etc. The latest treatment for macular degeneration is a longer-acting anti-VEGF molecule called brosilicimab, and its trade name is Beovu. It holds the promise of having the same beneficial effect with fewer injections. Now, I have never come across someone who's been thrilled at having an anti-VEGF injection into their eye. So the ability to reduce the treatment burden is immensely useful. However, this treatment has been delayed, like many things, by this coronavirus pandemic. The rollout of the drug has been delayed until later in the year, and our understanding of the drug is also being delayed by this pandemic. And what do I mean by that? Well, the drug has had TGA approval, but after TGA approval comes a period where we start to use the drug, and ophthalmologists compare notes, so to speak, in professional meetings and in papers about their experience using it, and that's called post-marketing surveillance. Then any things that may not have come up in the initial trials can be revealed and assessed, and so on. We do have two very good anti-VEGF molecules, Lucentis and Eylea, and for me to use a new drug, I would have to be convinced of two things. The first is its superiority in terms of the length of treatment, and the second is its safety. It would have to be as safe or safer than the existing treatments. And so both of those will need to be answered before I move my patients onto this new treatment.
Now, this is a multi-stage question, so I will read it to you in portions. The first part is, what is the prospect of a cure for the restoration of normal sight to a person with dormant end-stage wet AMD? What form may this cure take? And how far away in years would this cure be available for the public?
Okay, so a cure is a very high bar in medicine. It means in macular degeneration that not only do you repair the genetic abnormality that caused macular degeneration, you repair and restore macular function to completely normal. For example, to the level that a person of an age who doesn't have AMD would have it. Now, the genetic part, there is a pathway to a treatment that restores the genetic abnormality that causes macular degeneration to a normal version of that gene. And that is called in vivo gene editing. And people may have heard of CRISPR, CRISPR-Cas9, CRISPR-Cas9, as a prototype for a new generation of gene editing technology in people whilst they're alive. So this is not gene editing in an embryo, this is gene editing in a person. And so it may be possible that in the next decade, we will see progress in that to be able to gene edit away the genetic abnormality that causes macular degeneration. But this question is quite specific. What happens in someone who's already had macular degeneration, who has had damage to their macula? How can that be repaired and restored to normal macular health? And unfortunately, there is no pathway at this stage to that. So if you think of your macula or your retina as a perfect lawn with grass that is, like grass on the MCG, absolutely perfect. And then you see macular degeneration as a combination of dead grass, bare earth, and weeds. You would have to excise that area and restore it with either like a drop-in grass or allow it to grow again. And we don't really have a pathway to do that. So I wish we did. When I finished my fellowship at Moorfields in 2000, I was expecting that by 2020 we would be a long way down this path. But as we can see in this COVID crisis, the amount of medical advancements that a society expects is directly proportional to how much, as a society, we're prepared to pay for research. And if we make research a primary goal in our healthcare, then we will accelerate these sorts of developments. And if we don't, then these developments are delayed. So at the moment, I'm afraid I don't have any good news in terms of retinal regeneration or repair in macular degeneration. So that is a hurdle, a mountain that is yet to be climbed.
Can I add to that question, Dr. Qureshi? What about the very small studies that were done with stem cells, embryonic stem cells? Is there anything perhaps in that line in the future?
So the answer is yes, but just remember this, that your retina is like a microchip. Not only will the cells need to be regrown, they will need to be joined up in a way that is understandable. A microchip is just silicon. It's very similar to sand, but a sand doesn't do any microprocessing. It has to be organized in a highly ordered pattern to have its effect. And so the second part, so we do have stem cells, and we've got to that development, but what we aren't able to do just yet is to be able to organize them in a way that allows them to connect up and act like a computer chip and provide meaningful information to the optic nerve and to the brain. Otherwise, it's just like snow on a computer screen. Now, some practices in the United States have sought to bypass that and inject stem cells directly into the eye, but unfortunately the results have been catastrophic, where vision has got worse, where the eye has been permanently damaged, and in some cases has had to be enucleated. So I would not recommend stem cell therapies in private institutions overseas without it outside the scope of a clinical trial at a reputable university department.
Mm-hmm. So that brings us to another question about treatment. Dry macular degeneration. Is there anything in the pipeline regarding dry AMD?
So I want people to think about your retina is like the wallpaper inside the back of your eye. And if you lay that out, think about it like the MCG. The macula is the center of that MCG. It's like the Wicket square. It's the most important part of the retina. It's central. It's where we get our central vision from. Now, dry macular degeneration is, for those who are familiar with cricket, it's like a fifth-day wicket. It's where there are patches of dry earth where there is no grass. Around them, there's grass. It may be healthy or it may be a little bit thin, but dry macular degeneration is the absence of retinal cells in the retina, the photoreceptor cells, the rods and cones that do the same. And so to treat dry macular degeneration is to repair, restore, or regenerate those cells, to regrow them. And using that cricket and grass analogy, in grass, it's very easy. You just buy turf and you relay turf, and it's very simple. In the macula, you have to regrow those cells. Transplanting stem cells into the retina to treat dry macular degeneration has thus far not been successful. And then, as I alluded to before, not only do we have to grow those cells, we have to get them to join up in a meaningful way. And to do that, we haven't cracked the technology to be able to do that just yet. So there has been lots of different therapies for macular degeneration. I myself have been involved in more than 10 trials for different molecules, including injections into the eye for macular degeneration, that have not been successful.
What about the laser study, so the lead study that was done with Professor Geimer at Sierra?
Yes, so I'm very pleased that you brought that up. So the laser, Robin Geimer for a very long time has been investigating the use of laser to treat drusen and to try and slow down the development of macular degeneration, the development of drusen and end-stage AMD. Now, the lead study has shown some effect of laser on macular degeneration, and its effect on dry macular degeneration will have to be replicated before it's believed. So in science, you need to have 2 different studies that replicate results before you proceed down that path. It shows some promise, and it is worthwhile doing further research down that task, but it hasn't yet reached the level where I make a clinical recommendation to a patient of mine to have that treatment. But again, very, very interesting work, and it's one of those things that gives us a clue as to what to do next, how to proceed further. And you know, I do hope it leads to something. I tend to be more cautious. I recommend treatment when there is strong evidence of benefit, and there is a difference between research evidence, which gives researchers like myself clues about how to proceed, and treatment for patients, which is a whole nother story, which you have to have sound, strong evidence that you're going to make a difference and not make things worse.
Often when I do the education seminars for the education team in Victoria, I get asked the question, which is better? Is it better to have dry AMD or wet AMD? And I'm never quite sure how to answer that one. What's your view on that?
So let's begin with the terminology. Dry and wet are what is commonly used, but let's be clear that all macular degeneration begins as atrophy or dry macular degeneration. So using my cricket analogy, all macular degeneration begins when the grass on the wicket begins to thin out. It goes from being healthy, thick grass to being thin and developing micro patches where it's not absent. And we will all remember that when your grass is unhealthy or thin, little weeds can grow through the grass. When your grass is thick and healthy, it's very resistant to weeds. Now in the macula, they're not weeds, they're abnormal blood vessels, and those blood vessels leak fluid and blood, and we call that wet macular degeneration. But it begins as all macular degeneration begins with atrophy or microscopic patches of dry macular degeneration. So it's a combination of both. Is it better to have dry or wet? No, the answer is it's better to have neither. But if you are going to have macular degeneration, and let's face it, many of us, including myself, all of us are at risk because it's so widespread in the community, then the best way to approach it is to have some level of anticipation. So you're being monitored early on. You don't come to this late or by accident. You have a regular relationship with your optometrist who monitors the back of your eye and will pick up changes early, so you're well informed and you're being monitored, and you can use things such as an Amstel Grid to monitor yourself and pick up things early. So that is the best way to deal with macular degeneration. Unfortunately, we don't get a say in the diseases that we're going to get. We just have a say in how we deal with them.
And that's definitely a part that the Macular Disease Foundation likes to play a role in also. So we do have a few optometry students listening today, and the idea is that the Macular Disease Foundation will support people through their macular disease journey. And the idea is that if you can link your patients with the Macular Disease Foundation early on in their process, in their journey, we can then support them through it and make sure that they do have those checks, that they do go to those review appointments, that they do attend. It's definitely a collaboration. So that brings me to the next question, which is diabetes linked to AMD?
So diabetes and macular degeneration are both conditions that are more common as one gets older. So they are in some respects age-related, but you can have diabetes when you're young if you have a vulnerability or a poor diet and lifestyle. But in people over the age of 50, they seem to be age-related, but they are not linked. So they are both consequences of aging, but they're not linked to each other.
Okay. Now this one looks like it's come from an optometrist.
Yes.
I had a patient with a bilateral retinoschisis or macular retinoschisis. The ophthal, which is what we call you guys, thought it was an X-linked retinal condition. Any info? So
macular retinoschisis is a rare condition. It can be caused by being short-sighted or myopic. It can also be a rare X-linked condition, which means that it's on the X chromosome and it's inherited. And what that means is that the children get it from their mother. So boys get it and get the condition. Girls get the gene but can be a carrier rather than have the problem themselves. So X-linked retinoschisis is rare, but it may well be the cause of this problem, but there are also other causes, and it's caused by a specific gene. What's interesting about X-linked retinoschisis is it's going to be one of the relatively earlier genes to be targeted with this gene therapy that I mentioned earlier. So CRISPR-Cas9 is a gene editing tool, and think of it very roughly like a word editing, the editing function in a Word document, where you can delete out a misspelt word and replace it with the correctly spelt word. And in the single gene that causes X-linked retinoschisis is a suitable candidate for gene editing. And it may be in the next decade that we were able to have a treatment for this condition, especially early on. But it's very rare, and there are other causes of macular retinoschisis. And aschisis, for those who are unaware, is a horizontal split in the middle of the retina. It's a schitic, or a split in the middle of the retina, and can happen either in the periphery of the retina, in the outfield, so to speak, or in the macular region.
Great. Now, we have had quite a few questions coming in, so I'm going to sort of choose ones that cover a few of them so we don't run out of time today. The first question that someone has asked is, should I still continue to do the Amstel Grid test at home even if I see an ophthalmologist? Seeing an ophthalmologist can mean seeing an ophthalmologist once a year or seeing them once a month. As a general rule, I think people should use their Amstel Grid. I recommend to my patients that you do it at least weekly with each eye separately, and so that you get a handle on what the central vision is doing in both eyes on a regular basis. So the answer is yes, generally speaking. Right. There's another question that's come in. It's a little bit more specific, but maybe you could talk generally around it, Dr. Qureshi. It's I have a retinal membrane growing on my right eye, diagnosed around 12 months ago. At what stage should I have it removed? I also have bilateral dry macular degeneration.
It's very hard for me to give specific answers for a specific clinical situation, because it relies on the fact that the information transmitted is correct. There are different types of membranes. There's an epiretinal membrane, there is a choroidal neovascular membrane. There are also membranes that are vitreoretinal traction membranes, diabetic membranes. So there are different ones, and there are different strategies for both. So this is something where I would recommend that you speak to your ophthalmologist, because there are a variety of different ways to treat it, depending on exactly what it is, how severe it is, what are the consequences, etc. So it's almost impossible for me to give you an informed answer for a specific question like that.
Mm-hmm. Cataracts, of course, are a bit of an issue in this same age group, people in their 50s and onwards. Is there any risk to the macular disease degenerating quicker if you have cataract surgery?
So that's an excellent question. It was a question that as ophthalmologists we struggled with for a long time, and then there was a series of studies that were very influential, and the answer is there is no risk to worsening macular degeneration with cataract surgery. So cataract surgery and macular degeneration don't seem to affect each other. You can have your cataract surgery safely in the knowledge that it won't either accelerate or worsen or cause any complications to macular degeneration. So no, please feel free to have surgery if that's what your ophthalmologist has recommended.
Mm-hmm. Now, I've got a couple of further questions, which are a little bit more of a general nature, but I thought it would be great to ask them just for a little bit of variety. For people with severe vision loss due to end-stage wet AMD, what new technology device, if any, do you recommend to your patients as the go-to device to assist them in their daily tasks? There's a curly one for you, Dr. Qureshi.
Okay, so if you have poor vision, poor central vision in both eyes, then there are a variety of things that you can do, but they rely on, firstly, the level of comfort that you have with technology. If you're not comfortable at all, then you can see whether you can become comfortable using it. The second thing is to practice with it before you buy anything. So technology these days is very expensive, and the last thing you want to do is to buy something that is of no use to you. So I'd recommend whatever you try and do, try it in the store extensively before you buy it. You can use, so certain companies such as Apple and Microsoft have taken substantial steps in making their devices accessible for vision impaired people. The iPhone has an extensive ability to interact with it without good eyesight, and some of my patients who have an iPhone use the Siri function or use the voice commands to get it to do various things. Some people are very comfortable doing that, other people just don't know how to do it. So again, if you're going to go down the technology route, go and test it in the store and have specific questions in mind that certain things that you want to do that you can no longer do. So if you like to read and you can no longer read, then the ideal solution to you is an audio book. Some people will like that. Other people will fall asleep listening to an audio book and they might not wish to do that. So you have to tailor technology to suit exactly what you want it to do. And technology may sound very, very useful in the general sense, but you've always got to make it relevant to your personal needs and circumstances. That would be the best advice that I could give. Your ophthalmologist will know the specifics of your condition and what type of vision loss you have and what they would recommend. It's very hard to give a general recommendation based on disease.
It's actually probably a good place for me to also jump in. We have a low vision webinar coming up in the next few weeks, and we have someone coming from Quantum, and they do home visits where they'll come to the home and they will sort of see what issues you're having around the home, what help you could use, what tasks you're struggling with, and then they can help identify devices that may help you. So that might be a webinar worth looking at if you have questions around that as well. I have some more questions, Dr. Qureshi. With end-stage AMD, why do you need to continue anti-VEGF treatment?
That's an excellent question. It depends. If you have geographic atrophy or dry macular degeneration, then you'll probably need fewer injections than you would otherwise need if you didn't have that condition. It depends on the nature of your macular degeneration. So even if you have poor central vision, the area involved may be small. And going back to the cricket analogy, if you had a patch of grass missing, which was a foot by a foot centrally in the wicket square, then that's very different from a patch missing where it's 10 feet by 10 feet. So if you have aggressive macular degeneration, your ophthalmologist is treating you because he's concerned that if he stops treating you, the disease will come back and the patch that is missing from your central vision will increase in size, double or triple, then that impairs your functionality, your functional vision, your ability to move around your home, to care for yourself, to cook, etc. So there is, so it's not just the ability to read numbers on the chart. It's the size of the area that is damaged in your central vision. And sometimes, even if your central vision is poor in both eyes, you may be having ongoing treatment because if you stop having treatment, you may be your macular degeneration may be of that type that will explode again, so to speak, and become aggressive and active and cause far more vision loss than it otherwise would. So I've had this in some of my patients who have poor vision centrally, but when we've tried to reduce or discontinue their treatment, their wet or neovascular macular degeneration becomes very active. There's lots of bleeding, and there's a chance that a lot of damage can be done to functional vision.
Great. And I think we're coming time-wise, we're down to our last question. I think we will need to wrap it up after this, Dr. Qureshi. So the last question for this morning is, can wearing Polaroid sunglasses in bright sunlight regularly and frequently help prevent AMD?
I wish that were the case. The sunglasses sold in Australia have to meet a certain government standard for safety and to have a UV filter to be called sunglasses. So I think the UV filter is important to the surface of the eye, but just remember, your natural crystalline lens contains a UV filter, and that UV filter protects the retina. And intraocular lenses sold in Australia all have a UV filter. So if you go have cataract surgery and an intraocular lens is placed in your eye, that comes with a UV filter. Polarized light itself has no added advantage or disadvantage other than it reduces the amount of light by half that is coming into your eye and can improve your contrast sensitivity, but it will not affect the health of your retina one way or the other.
Mm-hmm. Well, thank you so much, Dr. Qureshi. I think it's been a fantastic session this morning. When I initially approached Dr. Qureshi to partake in this webinar, he said, "Oh, can we not do just a lecture because it gets really boring?" And I think during the Q&A was a great suggestion. So thank you so much for that.
No, it's my pleasure. I really hope that everyone has had some benefit from it. Thank you so much for inviting me.
Thank you. Now, today, of course, this webinar has been brought to you by the Macular Disease Foundation Australia. The foundation was established in 2001, and our focus is supporting people living with macular disease in Australia, and that's all kinds of macular disease. We do that through various pillars of work. Firstly, through our education seminars. We host these face-to-face seminars all around Australia to community groups. And the idea is we're just raising awareness of what AMD is, who's at risk, what you can do to reduce your risk and improve your outcomes. In the last year, we have presented to close to 7,000 people around Australia. And of course, now we've spread out into webinars, we hope to reach a lot more people. The second part of our work that's also important is creating awareness. So the foundation was largely created in 2001 because there wasn't a great awareness of AMD. I know in my own practice that people often don't really know what the macula is. They know the age-related part and they know the degeneration part because other bits degenerate as we get older, but they're not really certain what the macula is and where it is in the eye and what it does. And so the foundation's creating awareness around that, making sure that people know that AMD is the leading cause of blindness and that there are things that you can do to slow its progression. And so we do that through campaigns, particularly in May, which we've coined Macular Month. Macular Month was created as a time where everyone focuses their attention on the macula, particularly ophthalmology and optometry, and you'll see lots of things in the media in May about the macula. The focus, of course, though, with the foundation is our client services, supporting the people living with macular disease. And I will be talking a little further about that in a moment. And advocacy is also a huge part of our work. And this is the work that gets done behind the scenes. The anti-VEGF injections that we've discussed today were initially not PBS listed when they first became available. and they were very expensive, and the treatment was perhaps beyond what some people could afford. It was only through advocacy and discussions with policymakers by groups like the Macular Disease Foundation that these injections became PBS listed and have made them more accessible to the general community. We also do a lot of work with MBS in terms of your out-of-pocket expenses. So every time you go to your medical appointments, you may incur an out-of-pocket expense, and the foundation works very hard to ensure that that doesn't increase over time and become more burdensome. The research is a huge part of our work. Of course, ideally, we would like to prevent AMD occurring, and if not that, then at least finding a cure. Since 2011, the foundation has contributed $3.6 million to research grants around Australia to 18 different research groups, all looking at the macula. And of course, the hope there is that we will find a cure. And lastly, but definitely not least, it's our fundraising. We are not able to do the work that we do without the generous support of the community and of people like you, and we thank you for that. All of our resources and information is free, and we can only do that thanks to the generosity of the people that contribute to the foundation. So we were talking about client services. How do we help? What does the Macular Disease Foundation do? Well, the crux of it is mainly our 1-800 number. That's a toll-free helpline, and that's a number that you can call at any stage in your journey when you have questions. So you may have been to the optometrist and they may have talked to you about drusen, and you go home and you think, I don't really understand what drusen is. You can give us a call on 1-800-111-709, and a vision scientist will answer those sorts of questions. We have a huge amount of resources available also at no cost. So the resources cover all types of disease information booklets, advice around diet and lifestyle changes you can make. We also can direct you to services that you might require. So we were talking about low vision before and devices. There is a host of different providers available all around Australia. And the foundation really is just a conduit to allow you to find what works for you in your area. We also have great advice on My Aged Care, the NDIS, any type of question that you may come across, we're always happy to answer. You can go to our website, which you can see listed there, and access any of those resources, and in fact, order them and have them sent to you. And if you have any additional questions that you'd like answered, you can always email us at education@mdfoundation.com.au. And so lastly, I would just like to say that it's been so fantastic that we've had so many of you join today. You will be receiving an email from us after the webinar, and the email contains a link to our survey. Now, we ask you if you could please answer the survey, fill out the survey. It's a really important way that we can tailor our webinars to suit your interests, make sure that they're informative and interesting, and it's a great feedback for us to improve what we do. When you fill out the survey, you can also request to have the Amstel Grid sent out. So you'll remember we were referring to that before. This is that little one that has the little magnet on the back. We can send you one of those. And in addition to that, we also have the booklet. So this booklet actually covers a lot of what we've talked about today in terms of diet and exercise and what the disease is and some of the processes. So you can access that through the survey also. But lastly, and definitely not least, I'd like to thank you all for being here. And I would especially like to thank Associate Professor Qureshi for his time. It's been a really worthwhile venture, and we really appreciate you coming on today.
It's been my pleasure. Thank you very much for inviting me.
Thanks, Dr. Qureshi. Take care, everyone. Thank you.